All right, good afternoon and welcome. My name is Kat Patterson and I am a senior analyst on the Maternal and Child Health team at the Association of State and Territorial Health Officials, or ASTHO. I'm excited to welcome you today to the ASTHO Connect on using telehealth to address substance use disorder in maternal and child populations. This work is made possible by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Their ongoing support means we can organize events like this, bring together inspiring subject matter experts, and host conversations that help improve public health across the country. We'd also like to take a moment to disclaim that any information or conclusions in today's presentation are those of the presenters and do not reflect any official position or endorsement by HRSA, HHS, or the United States government. Please feel free to reach out to us if you have any questions or concerns about this. We're thrilled to have the opportunity to hear 3 different presentations today on using telehealth for substance use disorder treatment in maternal and child populations. We'll start with ASTHO's in-house telehealth experts for an orientation to what all telehealth entails, and then hear from 2 different programs, one in New Hampshire and one in South Carolina, for their experiences and lessons learned in this field.
Moving right along, the objectives for today's learning session are to describe the telehealth continuity of care, focusing on the 4 modalities of telehealth and how they can be leveraged to improve care, share information on how states have used telehealth for provider workforce development and to improve behavioral health outcomes for maternal and child health populations, and demonstrate potential ways that state and territorial health agencies can leverage telehealth to improve behavioral health outcomes for maternal and child populations. All right, next slide. And without further ado, we'll now introduce our first speakers, Alex Curley, Director of Medicaid and Value-Based Payment at ASTHO, and Janet Okuda, Senior Analyst on the Clinical to Community Connections team, also at ASTHO. To learn more about today's presenters, we have a handout with speaker bios and contact information that we will distribute. Please type your questions for our speakers into the chat box, and we'll answer your questions at the end of all 3 presentations. Janet and Alex, the floor is yours.
Thank you, Kat. So as Kat mentioned, my name is Janet Okuda, Senior Analyst at ASTHO, and I'm presenting alongside my colleague. This is Alex Curley, and we will be presenting on telehealth. Okay, so what is telehealth? Well, in short, telehealth is the use of technology to support and promote long-distance clinical health. Conferencing includes real-time audio and video communication between a patient and provider. Store and forward is the transmission of data, images, sound, or video from one care site to another for review by a health practitioner or specialist. The third modality is mobile health, which includes an application that includes health services and health education that is provided through a mobile device or some sort of electronic application. And remote patient monitoring, which are services in which a patient's vital signs and other data are collected at home or outside a clinic and transferred to a provider for monitoring and response. Sorry, everyone, I hope you can hear us. We're just having some technical difficulties. But on this slide, we provide you with some telehealth examples, some pictures that show all of these different modalities. So on the left side, we have remote patient monitoring, which shows a patient who's receiving some blood pressure monitoring in the home. On the right side, we have live video conferencing, where you see a provider communicating with the patient and another provider through a computer screen. And on the bottom right-hand corner, you see a mobile health application for heart rate monitoring. So for this slide, we wanted to provide you with an example of a telehealth modality for store and forward, which is e-consults, also known as electronic consultations. E-consults are asynchronous, consultative provider-to-provider communications within a shared electronic health record system or web-based platform. They're intended to improve access to specialty expertise for patients and providers without the need for a face-to-face visit. Another example that we provided includes the Project ECHO model. The ECHO model breaks down walls between specialty care and primary care, and it links expert specialist teams at an academic hub with primary care clinicians in local communities, also known as the spokes of the model, using a virtual Zoom-based platform. So during ECHO clinics, you have primary care clinicians from multiple sites joining through Zoom, presenting patient cases to specialist teams, and receiving feedback and guidance on patient treatment and care. So telehealth is covered in different ways by different payers. For Medicaid, they reimburse for live video in 50 states and DC. Store and forward is reimbursed in 14 states, and remote patient monitoring is reimbursed in 22 states. 40 states and DC have private payer laws, and the telehealth coverage and payment parity varies across states and by individual health plan contracts. For Medicare, before 2019, mostly only live video was covered, but after 2019, they passed a regulation called the Communication for Technology-Based Services, which added codes for different modality areas such as remote monitoring, synchronous virtual check-ins, et cetera. In 2019, Medicare Advantage regulations expanded telehealth delivered services in eligible locations. Okay, so for the rest of our presentation, I'm going to pass it over to my colleague, Alex.
Great, thanks, Janet. So I wanted to briefly share a few state examples that are very engaged in the telehealth space in this way. So beginning this year, Montana, who has the 6th highest maternal mortality rate in the country, launched the MOMS program, or the Montana Obstetrics and Maternal Support Program, with HRSA funding to improve health outcomes for pregnant and postpartum women. So this model includes several components, including a Project ECHO model connecting rural clinic providers to specialists, including OBGYNs, to share experience and expertise on a variety of issues, including substance use disorder counseling and MAT therapy for pregnant and postpartum women. This program also features a provider consultation access line, which is a dedicated line for rural providers to receive case consultation, as well as simulation and motion trucks, featuring experts who travel to rural hospitals and clinics to provide expert hands-on training. And this program also features telemedicine, so what you might think of as more direct to consumer or patient care, which connects expert hubs to high-risk pregnant and postpartum women at rural clinics, and also provides funding to purchase iPads for patient use. So we also wanted to outline what's going on in states in terms of research in this space, which we know is as additional research is needed in terms of comparative effectiveness research for telehealth. So PCORI, or the Patient-Centered Outcomes Research Institute, recently awarded Yale funding to compare 2 approaches for supporting OBs who treat high-risk pregnant women with opioid use disorder. So in short, this compares a more traditional collaborative care model, including a care manager to perform case management and care coordination, to a telehealth model which uses Project ECHO to provide remote education to obstetricians. So this study will ultimately look at which model is more effective for patients. And so I wanted to also just discuss some of the other factors that influence telehealth adoption. So Janet already shared a bit about the coverage and payment piece. In terms of clinical practice and licensure portability, what often comes to mind for folks is interstate compacts. So these are very important in telehealth as they allow practice across states. Currently, 29 states participate in the Interstate Medical Licensure Compact. 12 states participate in the Psychology Interjurisdictional Compact. And also teleprescribing has gained recent attention, largely as a result of the opioid epidemic. In terms of technology implementation, broadband we know is a major challenge in rural areas. The Federal Communications Commission has released a request for comments to inform a new funding opportunity, which is expected to be released in the year ahead. And also another challenge is the lack of provider and patient buy-in and uptake. Provider confusion remains about what services can be provided and reimbursed via telehealth, as well as how telehealth fits into the everyday clinical provider workflow. So wanted to share a bit as well about ASTO's telehealth portfolio. We've been supported by HRSA for the past 2 years to operate a telehealth learning community, working closely with Florida, Hawaii, Montana, and Pennsylvania. We've also developed several resources, which are highlighted on the last slide, and also launched the first telehealth state capacity survey, which we'll talk a bit more about on the next slide. So in 2019, ASTO launched the first survey of its kind to assess the current landscape of telehealth activities within state and territorial health agencies and in partnership with other agencies and stakeholders. And so on the next slide, we wanted to just briefly share some of the findings from the survey. So as you can see here, the most common type of telehealth services provided were directed toward healthcare providers and public health professionals. So this includes models like Project ECHO or other e-consult models. You can also see that the highest priority populations did include maternal and child health populations and behavioral health and substance use disorder populations. Some of the challenges included funding for telehealth services, patient and provider uptake and capacity and infrastructure barriers. States and territories also shared some of their most notable achievements. So the most common of which were increased access to care, new partnerships, expanded range of services, and increased efficiency of care. And finally, we wanted to just share some of the telehealth resources. ASTO also works closely with the Center for Connected Health Policy, which tracks current state laws and telehealth reimbursement policies. Our survey is the first link here and also included some recent ASTO briefs on telehealth at the state health agency level. And our contact information is listed here, so happy to take any questions at the end of the hour. Thank you.
All right, thank you so much, Janet and Alex. Our second presenter today is Dr. Marcia Doyle, Quality and Clinical Improvement Director of the New Hampshire Citizens Health Initiative. As a reminder, please type your questions for her into the chat box and we'll answer them at the end of all three presentations. Dr. Doyle, over to you.
Thank you. Thank you, Kat. My organization is New Hampshire Citizens Health Initiative, and we reside within the Institute for Health Policy and Practice at the University of New Hampshire. We're an applied research institute and have over a 15-year history of bringing together cross-sector stakeholders, promulgating evidence-based practice and education. Today, we're going to talk a little bit about the Project ECHO that was referred to before. This particular one was on perinatal substance use disorder. So we're going to go to the next slide. So this is where we reside within the university. We're seen as a natural convener, and in our echoes, we often have up to 100 participants. We'll talk more about that as we go along. Next slide. Next slide. So we consist of 22 staff members, and in our network of providers and projects, we have about 1,900. 50% of the population of the practices participates in our projects or learning collaboratives. We currently have 4 ECHO learning communities that have launched, and these are some various other activities. We are funded by grants and some consulting. So we bring together about 401 stakeholders in 2019. If we go to the next slide. So this particular ECHO was launched as a partnership across the Northern New England Project ECHO, which began in 2016. And as reviewed before, it is a case-based learning format, and 3 agencies basically came together in a variety of partners to launch this ECHO. Next slide. These are all the telehealth components at the University of New Hampshire. We're a hub here. And so we have an advanced nursing education workforce where we're looking at partnering with rural areas to increase MAT prescribing. Project ECHO, we have an Amplify component. So this is a SAMHSA funded project and a CTN, a Clinical Trials Network project, in which we have an ECHO and medications for addiction treatment and corresponding in-practice coaching to ramp up the MAT prescribing in our state. Next slide. So about the network. So the network launched this particular ECHO, the perinatal substance use ECHO, in 2018. And this project was really focused on disseminating perinatal substance use knowledge across Northern New England states in collaboration with several partner agencies that included the Area Health Center and Northeast Regional Health Center. The sessions included, the whole network sessions included perinatal SUD, continuum of care, and medications for addiction treatment and dementia care, but we'll be focusing on perinatal SUD. Next slide. So the focus was to increase the understanding and extent of substance use during pregnancy throughout Northern New England, outline how to identify potential substance use problems using screening protocols during pregnancy helps support and facilitate continuity of care for pregnant women with substance use disorders and their newborns throughout the prenatal period. So as you can imagine, this Northern New England network, I'm going to show you the next slide actually, and you're going to see the range. Okay, one more slide before that. So this is a picture of actually the participants participating in the perinatal echo. This is via a Zoom platform. So these particular participants are across 3 states, Maine, New Hampshire, and Vermont. And they participated in 8 one-hour sessions conducted monthly from February to September. And we had a multidisciplinary faculty. So family medicine, obstetrics, nurse practitioners, perinatal, clinical and psychologist support, addiction pharmacists, treatment pharmacists. We also have a librarian often that participates. So you can see here that they're all have their Zoom cameras on, they're learning and they're engaged. And this is what we generally see in our echo participation. Next slide. So here you see that there are the breakdown across the 3 states. And one of the nice things about the Northern New England Echo, which brought together a variety of partners, was perhaps in one state there wouldn't be enough participation, but across the 3 states you see more participation and you get new ideas about how certain areas or communities might resolve certain challenges. So for this particular echo, in Maine had 10 sites, in New Hampshire had 6, and Vermont had 3. There are 37 unique participants, primary care, OBGYN, family practice, over 19 sites, and we average about 17 participants per session. Now this can vary greatly. We have just a New Hampshire medication for addiction treatment echo that we run that I had referenced before, and we can have up to 70 to 100 participants. So the participation varies. We have a lot of engagement in both this particular echo and the medication for addiction treatment echo, which also deals with perinatal and women in substance use. Next slide. So one of the biggest things about our work in quality improvement and dissemination of information is really to understand what our participants' needs are. As a natural convener, we really want to understand, you know, what is working, what is not, what do we need to do to get the information out. So ECHO is known to improve knowledge and confidence in treatment. Studies have shown that, but it doesn't necessarily equate to boots on the ground actually delivering the work. So when I spoke earlier about the ECHO Amplify, that was actually an added component of a learning collaborative to enhance the ECHO, to really move us forward and say, okay, now you have the knowledge on the ECHO, but how can we apply it within your practice via practice facilitation and looking at data? So this particular perinatal echo was evaluated, and 99% reported that technology was effective for the didactic in the cases. This is really important. As you can see, even with this particular Zoom learning that we just had, there's glitches, but we were able to overcome the glitches. So really understanding what they are and being proactive about it is essential in terms of maintaining good attendance on the echo. 88% felt that the facilitation was good or excellent. We have facilitators, we have MDs, NPs, behavioral health. It depends on what the facilitator is consistent across the cohort, but it really just depends on what the grant is, who we have that's an expert, and who's a good facilitator. 93% found the quality of materials to be good or excellent. So for some of our echoes, we always put out a case recommendations form following the case presentation, but we also put out the librarian does an extensive search and she collates information, and we send that out as well. And that's really to help our participants, because we know that they don't always have access to peer-reviewed journals right at the tips of their fingers. 77% took advantage of the CME credits offered. So there is a cost to offering that. For our MAT Echo, it's almost $5,000, but we're providing CME to a large extent, a large population. We go for CME for as many disciplines as we can, because we want to encourage team-based participation. Next slide, please. 94% reported the faculty presentations as good or excellent. So the faculty presentations are usually those that are also giving the recommendations. They're usually considered the faculty, but we also sometimes occasionally have guest speakers. These are people that may not be present the entire length of the cohort, but have special expertise where they can come and speak. That has happened in particular in the MAT Echo. 90% reported faculty knowledge of the topics as good or excellent, and 94% had a good or excellent overall impression of faculty. 92% rated contributions from faculty members as good or excellent. This is really important because you want to not just gain knowledge and confidence in your community of practice learners, but you want them to feel confident that they can actually implement it in practice and to reduce that 17-year stint of information being out there, but not necessarily being able to apply it. Next slide. So this is participant satisfaction. 88% usefulness and value of the didactic was good. 99% didactic appropriate for educational needs, good or excellent. And 87% value of discussion sections, good or excellent. One of the things that we have done even more work here in New Hampshire to make sure that we are only filling the educational needs is to be doing surveys. So we are doing snowball surveys, qualitative information gathering. We're also doing claims-based analysis to make sure that these didactics and these echoes are important to our state and our population. So sometimes we're measuring, what is the geodesic distance between being able to get perinatal care and where you live. And so saying, can we provide care higher quality, closer to home, and how can we get that to that community? Next slide. So this is an additional evaluation results on knowledge and competence. 96% reported the enhanced competence. 88% reported the didactic influence their practice. So again, remember, for this particular echo, we're not going into the practice and seeing before and after what happened, but that is highly plausible and one could do that. It just takes more resources. But we are excited about the results that we have here. 75% reported it impacted patient outcomes. And for this particular echo, we did not have them report on specific health or EHR-based outcomes or claims outcomes. But in subsequent echoes, we are doing so. Participant response rate to case presentations, 81% reported that case presentations enhance their competence. 71% reported that case presentations influence their practice. So this is one area to really kind of look more into, and we're in our Amplify study, we're kind of identifying some of the areas that are challenging. Culture, stigma, not everyone is adopting a harm reduction approach. Things are sometimes slow to change, the availability of workforce to come together and really address patient needs. 58% reported it impacted patient outcomes. So knowing the death rate of opioids in our state is very high, these are important things to consider and in terms of developing additional resources. Next slide. So some of the takeaways, people felt that they were more confident in speaking publicly about the needs of SUD participants and moms and infants in particular. It was useful to meet other providers and engage in this network in understanding some of the barriers they face. By ending these echoes, we often see folks refrain from presenting cases in the beginning because they think that they need the most complicated case. And towards the end, we start to see people presenting challenges within the clinic setting that impact the care. And so it's really refreshing to see. We also see people who are newer at treatment for these chronic conditions actually leading cases. Their other findings were that hoping to offer more support to new mothers, screen for PPD, offer support group. It was nice to see faculty input that aligns with what we receive in similar case consultations. consistency processes. So a lot of things are happening on a curbside consult basis, and if there isn't access or time, that curbside consult may not happen. But if these folks have a place to go every month, they know that they can ask questions or prioritize a case to be reviewed or have a phone number from one of these faculty, it's been beneficial. We plan to check in monthly with the MAT prescribers for all our pregnant patients. For our specific case presentation patient, we plan to retest for HIV and Hep C and reassess for depression. So these are some real actionable steps that this particular practice took to improve care. We consistently advocate for comprehensive support for this population, encourage more complex case management and engagement of additional partners like DHHS, law enforcement. And so one of the things that we've done in our newer echoes, DHHS is involved in our MAT echo. And so it's been going quite well. Next slide. So the successes are really regional, first regional project echo session across 3 states, many stakeholders, created a regional community. Dr. Jean Ryer, who was supposed to speak to you today, actually brought ECHO to New Hampshire. She was unable to join us, but it was instrumental and is definitely changing the way we are able to engage with one another. National best practice leaders on faculty promoted interdisciplinary team practice in terms of our groups that join, raise knowledge and awareness and confidence in provider teams. And the challenge is that it's cross-cutting design over multiple specialties and targeting curriculum and didactics to varied levels and multiple specialties. Scheduling, promoting best practices in local practice cultures is really a challenge as well. The other big thing here, and it's not mentioned in this particular evaluation, but is there really is no reimbursement mechanism in New Hampshire, at least, and I think it's nationally, to what happens if you participate in these. It's a loss of RVU, and that's one of the things we sometimes hear. This particular echo was 1 hour long, but some of our, during lunchtime, but some of our other echoes are 1.5 hours long, and that's a challenge in this kind of environment. So I want to thank you for the opportunity to present this materials, and I want to invite you, if you are interested in sometimes sitting in, if you're in this area, we will be launching a pediatric echo for depression and anxiety in March, and our cohort 2 of our MAT echo will launch in February, or we can also talk about secure lines so you can witness it's a de-identified case presentation and didactic. Thank you for your time today, and I hope this was helpful.
Thank you so much, Dr. Doyle. That was a pleasure to hear. And last but not least, our third presenter is Dr. Constance Gill, Associate Professor of Psychiatry and Behavioral Sciences and Obstetrics and Gynecology at the Medical University of South Carolina. Welcome, Dr. Gill.
Thanks so much. It's really a pleasure to be here, and thanks, Dr. Doyle, for that great presentation. That was really great to hear about all the work you guys are doing in the Northeast. So I'm going to talk today a little bit about kind of more focused substance use treatment in pregnant and postpartum women. Our program has really focused on opioid use disorder because that's a big focus of our clinical research. However, it really could be applied to any sort of substance use disorder in pregnant and postpartum women. Next slide. What I hope to talk about is telemedicine, and Kat and Janet did such a nice job already just kind of outlining what these modalities are. So I'll talk about how we use telemedicine, which is directly to an OBGYN practice to treat pregnant women with opioid use disorder. And then there's a lot of talk about ECHO. I'll just highlight some of the things that we've done in this area. Really, ECHO's really main job is to increase the workforce and having community providers taking care of these patients. And then if there's time, I might be able to talk a little bit about some of the work that we're doing to take some of the screening and care coordination that should happen around mental health and substance use disorders in pregnant and postpartum women, and how we're trying to leverage technology to improve that. Next slide. And these are just our disclosures, kind of if people are interested in how we've supported this work for our telemedicine work. Actually, we have a Center for Telemedicine at MUSC, Medical University of South Carolina, that receives some state appropriations of funds every year, so that helps support our program. We've also been supported by the Duke Endowment, and we have a HRSA Center grant, which really allows us to do the evaluation component of the work that we do in telemedicine. For Project Echo, as Dr. Doyle mentioned, financially there is not a lot of support for this. We've partnered with our state agency to use STR and SOR funds, state targeted response and state opioid response funds. And more recently, we have a contract with Anthem to support that work. And then the mobile phone screening and care coordination that I mentioned is supported through the National Institute of Drug Abuse and also Duke Endowment. So next slide. So getting into some of the reasons why we focused on opioid use disorder is that we've essentially had a fourfold increase in this diagnosis in pregnancy over the past decade. It carries a really significant morbidity and mortality for mom, and also it has an impact on newborns. Pregnancy is just this amazing time to kind of bring women into treatment in that they're often very motivated towards positive health behaviors. They're afforded health insurance. They have regular visits with the healthcare system. So just multiple points of contact to try to help these women get into recovery. The way that we approach treatment for this population is really thinking about the mother-infant dyad and providing services for both. We also think about evidence-based treatments for addiction, which includes psychotherapy such as relapse prevention and pharmacotherapy. People have talked about MAT. What I'm going to talk about primarily today is the use of buprenorphine for the treatment of opioid use disorder. Also in this realm of treatment, we're really making sure that we're addressing comorbid mental health problems, any history of trauma or current trauma, and addressing the psychosocial needs of this population. So ideally, you're doing all of that, and then you are integrating that treatment into prenatal care, or vice versa. You're doing all that addiction treatment, and you're integrating prenatal care in an addiction setting versus an obstetric setting. But either way, integrating both prenatal and opioid use disorder treatment has been shown to increase retention and treatment. It's been shown to improve maternal and newborn outcomes, and it's cost effective. The problem is that just kind of nationally, we have a dearth of substance use disorder treatment programs that take this integrated model. Next slide. So I was just going to mention that, this issue of not having treatment programs throughout the United States for this population, this becomes even more of an issue when we get into rural areas where there's even less access to treatment and there's actually more substance use, particularly opioids. We see an increase, a greater rate of NAS, neonatal abstinence syndrome, and maternal opioid use in rural areas of the country in comparison to urban. Next slide. So telemedicine is a good way to try to overcome some of those barriers in getting treatment to folks. So essentially what we did is we have a program at MUSC where we integrate maternal mental health and substance use disorder treatment into obstetrics care. And what we wanted to do is see if we could actually take that program and insert it into OBGYN practices via telehealth. So we have a perinatal psychiatrist with addiction training that is able to consult and talk with patients on the other end and treat them. And the slide to the right is just our state and the demographics of our state. Next slide. So in doing this work, one of the first things that needs to be considered, especially around treatment of opioid use disorder, is the Ryan-Haight federal law, and there's also state laws as well to consider. And the reason is that if you are going to be treating opioid use disorder via telemedicine, that would include prescribing a controlled substance such as buprenorphine. And so back in, historically, we had a really unfortunate case of an 18-year-old boy, Ryan-Haight, who was able to actually just order Vicodin over the internet, and that arrived to his home in a package, never saw a physician or a provider, and overdosed on that medication and died. And as a result of that, this Online Consumer Protection Act was put in place prior to the opioid epidemic, prior to really thinking about telemedicine as a way to treat opioid use disorder. And it was really intended to target our rogue pharmacies that were doing this, that were distributing opioids without someone actually seeing a physician or another provider. And so a really good intended act. In practice, what's happened is that has prevented us from using telemedicine to prescribe controlled substances unless that person is seen in person first. And that's kind of the catch, right? If I could see someone in person first, I wouldn't need to do telemedicine. So we kind of get in this catch-22. So there's some exceptions to that. So exceptions to the in-person evaluation, which is that if that patient is in the physical presence of another provider that has a DEA license, you could prescribe to them via telemedicine. If the person is on an Indian health service or tribal organization in the VA system, if there's a public health emergency declared, we should be able to do this. However, even though the opioid epidemic is considered a public health emergency, there isn't a way to actually petition to be able to do this. The other exception is if you have a DEA registered hospital or clinic, then you don't need to see the person in person first in order to prescribe. However, there isn't a mechanism to register a clinic or a hospital or any setting with a DEA. And there isn't a mechanism to get a special registration. So currently right now, actually you can go to the next slide. The DEA was essentially given, there was proposed changes to the Ryan-Haight Act so that we could really accommodate the use of telemedicine to better treat opioid use disorder. And right now, the DEA has been tasked with rewriting some of the special registration for telemedicine so that people can be granted the ability to do this instead of those exceptions. So the deadline for this, we were hoping to have some clarity on this back in October. We're still kind of waiting to hear from the DEA to figure out how we can proceed with some of these areas. The next thing I would consider if you're figuring out how to do telemedicine in your state and you're prescribing a controlled substances is really to look at what your state laws are around that. We worked very closely with our state board of medical licensing examiners, and we're basically put together a large protocol to lay out how this service would be delivered and kind of putting in the safety guards that you'd want to have in place for this sort of service. And so we were granted approval from our Board of Medical Examiners to go forward with our telemedicine for pregnant women and OBGYN practices. So next slide. So once you've kind of navigated the federal and state laws and requirements, there's kind of this checklist, and it's a pretty large checklist to get through, but it's very, very doable. And just thinking about the basics of getting ready for telemedicine, the very, very first thing has to do with bandwidth. So can you be in a practice that actually can run their EHR and can actually run telemedicine equipment and software? Because without bandwidth, you can't move any further forward with a telemedicine service. So once you have that in place and know that that's available, the next step is equipment and getting that in place. There is then just designating who are the people that are going to be part of this service and putting that service agreement in writing and credentialing your providers in whatever way that site needs you to credential them. Some don't require that, some do. And then establishing your workflow and how this is all going to take place, everything from referral to scheduling to bringing the patient in to being seen to being able to get a urine drug screen at the time of their visit to being able to schedule follow-ups to being able to figure out who should that patient call when there's a problem. And for us, we are in multiple places, so we obviously want to standardize this as much as possible on our end, but really appreciating that every single practice that you go into is a little bit different, and they have different workflows and they have different resources, and so really needing to be flexible about how you implement in practice. Then the next step is really figuring out is doing the training and doing multiple trainings and making sure that you're timing that training as close to possible to when you could go live with a participant. Because if you train someone on equipment and then you wait 2 months, they're not going to remember any of that. And so really just doing mock patients and doing that over and over until you are ready to go with your first patient has been really helpful in our establishment and implementation of telemedicine. Next slide. So this is where we are in our state right now. So where I sit is at MUSC, and that's Charleston, where we are in yellowish orange, actually orange. And then the stars are where we are actually doing telemedicine. And the vast majority of these are OBGYN practices. We have a couple county drug and alcohol treatment centers where we do telemedicine as well. This is a couple of years ago, we were essentially in 4 places, and I would always recommend starting small. We started out with 4 sites and really kind of got our feet on the ground, kind of got a good sense of how this worked, and then could go on to the next practices. So this is where we are now. We're hoping to grow, but we were very slow to start. Next slide. So in terms of sustainability of being able to treat pregnant women with substance use disorders in our OBGYN practices, I mentioned our Center for Telemedicine, I mentioned our Duke Endowment. Our Duke Endowment is really designed so that our clinicians are now billing for their services, and that clinical revenue over time will hopefully support that service. But there, as you imagine, there's a lot of kind of coordination that needs to occur remotely for this population. If you're going to really treat opioid use disorders, you need evidence-based therapies, which we can't actually bill for at this point. We can only bill for an MD and an APRN's time in the state of South Carolina. And also we need help with care coordination and case management, and we are not able to bill for those in our state right now either. So there's a lot of things that still need to be supported to do this work. Next slide. So I cannot go into like a ton of detail about some of the work that we've done to evaluate our telemedicine program. This paper should be coming out at the end of the month, but it's under an embargo right now. But just to know that we essentially did a non-randomized control trial where we took 3 of our OBGYN practices and the women that were coming in to get opioid use disorder treatment there, and compared their outcomes to our in-person care, mainly looking at retention and treatment and substance use and NAS and length of stay for our newborns in the hospital. So can't say much more than that, but we are continuing to do this work and we're very excited about it. Next slide. There's actually, we've already talked a little bit about ECHO. I don't need to say much more about that. That was such a nice presentation from Dr. Boyle. We are doing the same thing here where we are just have an ECHO for opioid use disorder. So not targeted to pregnant or postpartum women, but just for opioid use disorder. And I tend to just give a lot of presentations on how to treat pregnant and postpartum women in this population, but it's probably not the same depth that you would get in Dr. Doyle's program. So this was started, essentially Dr. Kelly Barth and Dr. Karen Hartwell have kind of shepherded this ECHO, and they are being funded by SOR funds and also Anthem. We maintain a website of all of our didactics, all of the actual ECHO presentations that we've given, and that is posted on that website. Sorry, my screen just went blank because I wasn't touching it. So those are available for participants to download afterwards, or anyone else just interested in this area. Next slide. This is just to highlight that there is a very large evidence base that continues to grow to support the efficacy of ECHO. Next slide. And just a little bit about the anatomy of our echoes, which is similar to everybody's. Essentially, there's a case presentation from somebody in the community, followed by question and answers and recommendations. And then we have a relevant expert who's going to give a didactic in that particular area. But a lot of the things that we focused on, not just treatment of opioid use disorder, but also other comorbid substance problems, how to handle opioid use with pain, common comorbidities such as depression and anxiety. And again, that's our website. So next slide. So this is started out in South Carolina, but we've had about 8 states participating in this, and 85% of our counties in South Carolina have participated in our ECHO. Next slide. And this just gives you a sense of the number of ECHO participants by county in South Carolina. Next slide. So I think what's important about our numbers in terms of reaching participants in this area, this is for Project ECHO. This has been paired with buprenorphine waiver trainings where we've trained over 350 providers, and academic detailing where we have PharmDs that are going out to practices in our community to talk to people about treatment of opioid use disorder, and doing a lot of educational conferences. So a lot of that was just a way in which we could help people get into our ECHO series. Next slide. And as already mentioned by Dr. Doyle, that we need to figure out a way to sustain this sort of work. Next slide. And these are just my acknowledgements. I have a really great team and lots of support to do this work, which I'm grateful for. And I will turn it back to Kat or Janet for questions.
Thank you. Thank you. This has been just such a great conversation. We so appreciate it. At this time, we'd like to open up the floor to questions. So if you have any questions for either Dr. Gill or Dr. Doyle, please go ahead and just chat them in. Now, we did receive one question for you, Dr. Gill, already, and that was just a clarifier. Which journal is publishing your work this month? So if you don't mind potentially sharing the title of the article and then also the journal, just so we can keep our eyes peeled for when your paper makes its debut.
Sure. So it's JAMA Open Network, and the title is Treatment of Opioid Use Disorder via Telemedicine. And I can, I don't know if you have a list of people that you could distribute. When it comes out, I'm happy to send it to you all if you have a list of people that you distribute to the webinar.
Fantastic. Thank you so much, Dr. Gill. We'd be happy to share that with folks. We have another question, this one for Dr. Doyle. And the question is, can you share how you managed your echo clinics with larger numbers of participants, i.e. 75 to 100? And the asker says, I'm sure there were challenges with that volume, with that number of folks.
Sure. Yeah, so we have two large screens that accommodate 25 windows each. And so we were able to monitor some of it with that. The other thing is we started, the 18 sites, we're now down to 15. The practice sites, we work with the practices to make sure that they are in a room. So with one all together, because what we want to happen is that they're talking from their knowledge and professional viewpoint about these cases. So all 100 people are not on different windows because we really want them in the room. For an echo that has, which I didn't go into, the nursing students, we have an asynchronous family nurse practitioner program and postmaster's psychiatric nurse practitioner program. And for those students, sometimes we will have separate windows, but it's a lot of education up front. And we meet with each practice to onboard them for about 20 minutes. It doesn't have to be the whole team, but that also helps logistically and develop a rapport. So I hope that answers your question.
Thank you so much, Dr. Doyle. We'll give folks to continue to mull their thoughts over and see if any other questions pop up. But in the meantime, we did have a question for both of you, actually, Dr. Doyle and Dr. Gill, around funding and or reimbursement challenges. And so, Dr. Gill, you mentioned difficulty around case management and having those services reimbursed or just finding ways to get support for that. And so I wanted to ask you, let's just start with you, Dr. Gill, if you had any insight around funding or reimbursement challenges and how you've tried to problem solve those through Medicaid or otherwise. So kind of just talking a little bit more about some of those funding or reimbursement challenges that you've encountered and what you've done to overcome those.
Sure. Well, we're still working to overcome some of them. So our Center for Telemedicine does a lot every single year, is putting forward to the state Medicaid, just into Department of Health and Human Services, what we would want in terms of coverage for what we would need for these sorts of services. So every year we're asking for, can you cover psychotherapy? Can you cover case management? And so it's a constant going back to the table around this. However, and in addition to that, so while collaborative care codes are actually across the United States, a lot of people are able to use those. In the state of South Carolina, we can only use that for Medicare. It's the collaborative care codes for Medicaid are not supported yet. And so really working with our Medicaid folks to bring those on for this population in particular. So we're having conversations, we're meeting, and we'll just keep kind of pushing our way to do that. We're really working on kind of more cost-effective ways to doing that. So using technology to do more remote care coordination and more therapy. If they could support those things, we would need less personnel. So those are just some of the things that we're working on now.
Great, thank you so much, Dr. Gill. Dr. Doyle, so same question for you around funding and reimbursement challenges. What have you faced and how have you kind of problem solved those hurdles?
Yeah, so we are definitely a soft-funded, the initiative is soft-funded, and so isn't the Institute for Health Policy and Practice. We don't have an endowment or anything like that, and we're not a medical school. The challenge is to work with insurers for us to bring the education forward, but also, we want to look for sustainability in this model. We believe in this model, but also for our providers who participate, we want to be able to be forward thinking, and there needs to be some relief time for them to be able to participate. So we've been really active with the ECHO Institute in following the bills in Congress and their reports. And we've been really active here watching the telepractice legislation going through. And there really aren't any easy answers because really, realistically, the only minimal components of what is truly needed to serve these patients is being currently reimbursed. And in the mechanism that it is reimbursed in, it doesn't look at the whole payment or the whole picture. So that's really challenging. And it leaves a lot of folks without services or entities that are providing the services in the red. So we continue to work on it, work with legislators, but it's a challenge. It's a challenge, I believe, around the country.
Thank you so much. I really appreciate those thoughtful responses. We'll give attendees just a couple more seconds in case there are any burning questions that you want to chat in for either Dr. Doyle or Dr. Gill. Again, thank you so much for your knowledgeable presentations. It was a real pleasure having the two of you here.
Thanks for having us. This is great.
Thank you.
Yeah, absolutely. Thank you so much. And without further ado, let me turn it over to Vic just to close us out.
Yeah, we wanted to thank everyone for attending today's ASTO Connects. Please take a moment to complete our evaluation module via the link in the chat box. Your evaluation of this Connects is very important to us as we are always striving for continuous improvement. If you're unable to complete the module at this time, you will receive the evaluation link via email soon. Thank you very much and have a wonderful day.